On increased ICP. Miss T is a 72-year-old client who presents to the emergency department with new onset confusion, lethargy, and a headache. She reports a fall 2 days ago in which she hit her head on the side of her coffee table. She did not seek medical attention at that time. The provider suspects increased intracranial pressure, that increased ICP. So question 1. What causes increased intracranial pressure, that ICP? So go ahead and pause your screen and think of a few options here. Okay, so let's look at the options. So what causes that increased ICP? Well, an increase in brain tissue from swelling, bleeding with inside the brain, or even excess cerebrospinal fluid, that's CSF. So in this case, it's more than likely the first 2 points, that brain swelling and that bleeding, because she hit her head on that coffee table. Now, question 2. How does increased ICP affect cerebral perfusion? So pause the screen and just think of a few options here. Okay, so let's break down this case study question. How does increased ICP affect that cerebral perfusion? Basically, blood flow to the brain. Well, increased ICP has an inverse relationship with cerebral perfusion pressure, that CPP. When ICP is increased, the CPP is decreased, leading to a big key term, cerebral ischemia. Fancy words for low oxygen to the brain from that decreased blood flow, basically lack of perfusion. So CPP is calculated in the following manner. MAP minus ICP. And MAP meaning that mean arterial pressure. Now moving on to question 3. Which additional data will the nurse assess for? So pause the screen and think of a few options. Okay, so let's break it down. Which additional data will the nurse assess for? Option 1 here is further changes in the level of consciousness, that LOC. Yes, because remember, increased ICP, we have that increased pressure putting strain on the brain. So changes in LOC are to be expected. Also, changes in vital signs, namely Cushing triad. So remember, Cushing's triad for Cushing's triad. We basically have crushed respiratory rate and heart rate with a widening pulse pressure, basically meaning the blood pressure numbers are wide apart as the brainstem gets crushed from all this pressure inside the head. Now, the next 2 key points is unilateral pupil dilation and also vomiting, more specifically projectile vomiting. So all are classic signs of increased ICP. Now, moving on to question 4. Which assessments are included in Cushing triad? So pause the screen and think of a few options. Okay, let's break it down. Which assessments are included in Cushing triad? So as mentioned before, Cushing triad, we have a crushed respiratory rate as well as heart rate and widening pulse pressure. Basically, the blood pressure numbers are getting wide apart. So the answers here are bradycardia, that low heart rate, irregular respirations that typically always decrease, and lastly, the widened pulse pressure. We have a high systolic or systolic blood pressure and a very low bottom number for the blood pressure, that diastolic. Now moving on to question 5. Which assessments will the nurse monitor for in order to detect critical potential complications for increased ICP? So pause the screen and think of some critical assessments. Okay, so let's break it down. The question's asking for which assessments to monitor for to detect critical potential complications from that increased ICP. So some things you should have wrote down is bilateral pupil dilation. This is known as blown pupils. Basically, there's so much pressure within the brain that the pupils are dilating. Another one is decordicate posturing, where the arms come into the core for decordicate. And another critical assessment is slowed respirations. These are signs that could indicate brainstem herniation, as all that pressure within the brain pushes and compresses the brainstem, which controls respiratory and heart rate. Now for the practice questions on increased ICP. So question 1. The nurse is caring for a client post-traumatic brain injury. Which finding should be immediately reported to the provider? So pause the screen and try your best to answer this question in about 60 seconds or less. Okay, so let's break this question down following our two-step question breakdown strategy. So first, look at the key terms in the question. We have post-traumatic brain injury and which findings to immediately report to the provider. So think what kills the client first. So number 2, always think of a few things you know about those key terms. Specifically for brain injury, think what kills the client. So worsening increased ICP signs. Okay, now let's look at the options. So option A, a blood pressure of 114/78. So no, this is incorrect. This is actually a normal blood pressure. Now, if it was worsening, then we'd expect wide pulse pressure, with the top number and bottom numbers getting wider apart. Now, option B, a respirations of 18 breaths per minute. No, incorrect. Currently normal. Between 12 and 20 is normal. Now, option C, sleepiness. Now, this is very tricky, but it's wrong. This is actually an early sign of a brain injury. It's still very important, but not as the most important as option D, projectile vomiting. This is the correct option. So this key term, projectile vomiting, it looks like a stream of water from a water hose. The vomit comes out just like this. Now, this is a big indication of a critical brain injury. Now, moving on to question 2. Which assessment finding would alert the nurse that a client with increased ICP is experiencing a critical potential complication? So pause the screen and try your best to answer this question. All right, so let's break it down using our breakdown strategy. So first, always look at the key terms in the question. Assessment finding and client with increased ICP, and we're looking for a critical potential complication. So now think of a few things you know about those key terms. So increased ICP, remember, the brainstem is being crushed from all that pressure, leading to crushed vital signs, since the brainstem controls the heart rate and respiratory rate. And make sure you know these late deadly signs on the screen, as the most deadly signs are typically the most tested signs, since it will save the client's life. So I'd recommend pausing the screen and looking at the highlighted options here. Okay, now let's look at the answer options. So option A, a blood pressure of 108/32. Yes, this is the most correct. This is very wide pulse pressure. As you can see, the top number is very wide apart from the bottom number. So this is a classic sign of Cushing triad, where the brainstem is getting crushed. Now option B, a heart rate of 90 beats per minute, is incorrect. Normal heart rate is between 60 and 100. For Cushing triad, we would expect the heart rate to be below 60, that bradycardia. Now option C and D are both incorrect because a blood glucose of 92 is technically in normal range, between 70 and 110. But glucose is not a main indicator of increased ICP. And option D, a potassium of 3.8. So no, this is incorrect because normal potassium is 3.5 to 5.0. Just like glucose, potassium does not play a main factor in influencing ICP. Lastly, question number 3, which is the earliest indicator that a client is experiencing increased ICP? So pause the screen and try your best. All right, so let's break it down using our question breakdown strategy. So first, look at the key terms in the question. We're looking for earliest indicator of increased ICP. Now, number 2, think of a few things you know about those key terms. So early indicators typically have to do with mental status changes here. So recall the key points from the full video. We have altered level of consciousness with irritability and restlessness, as well as decreased mental status, sleepiness, and even a flat affect and drowsiness. Okay, now let's look at the options here. Option A, fixed dilated pupils. No, this is incorrect. This is a late sign, indicating brainstem is being crushed. Now, option B, bradycardia. This is also incorrect because, once again, one of the biggest indicators of Cushing triad where the brainstem is being crushed. This is a late sign. Now, option C, restlessness and irritability. Yes, I know the key terms are very tricky here, so be sure to know them. These key terms come up time and time again on the NCLEX, your exit exams, and even your nursing exams to describe changes in mental status. So please be sure to know, restlessness and irritability all associate with altered level of consciousness as an early sign of increased ICP. Now lastly, option D, slowed and shallow respirations. No, this is incorrect because, once again, it's a late sign as the brainstem is being crushed, which controls the respiratory rate. All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz and download the study guides. And also feel free to share the love, share with a classmate, and even your instructor. See you guys in the next videos. Meningitis is the inflammation of the meninges, which is the inner lining of the brain and spinal cord. Now, the meninges are comprised of 3 layers, sort of like a bean dip. We have the dura mater, the arachnoid mater, and the pia mater. This inflammation can cause massive swelling in the cranium, putting loads of pressure on the brain itself, and even leading to very deadly increased ICP, that increased intracranial pressure. That sort of squashes the brainstem and kills the patient. Now, the causes of meningitis are very simple, typically due to infection, head trauma, or even an autoimmune disease like lupus. But infection is the most commonly tested since it's the most common cause. So for infection, we have 2 types, viral, which is the most common, and bacterial, which is far worse since it's most contagious. So the memory trick we use is bacterial, think bad news, since it's the most contagious. And for viral, just think very common, since it's the most tested. Now, it spreads by being exposed to another infectious person. Very common in college dorm rooms where we have tight quarters, or even in hospitals like after surgery. Either way, it invades the CSF, that cerebral spinal fluid, within that subarachnoid space, causing major swelling and inflammation. Now, the key signs and symptoms to look for, think of the 3 H's since it affects pressures inside the head. H for headache and photophobia. H for hard neck, known as nuchorigidity, and H for high temperature. We typically see a high fever due to the infection. Now, for pediatrics or little babies, the 2 classic signs are a high-pitched cry and bulging fontanelles. These are typically the 2 most tested classic signs for ICP and meningitis in our pediatric patients. Now, in our adult populations, increased ICP is typically seen as agitation and altered level of consciousness. That mental status change. That's typically the most tested first sign. This will eventually lead to seizures, coma, and death as the brain gets squished under all of that pressure. But we cover all of that in the increased ICP video. Now, as far as diagnostics, the priority findings to report immediately. So guys, write this down. Positive Kernig's and positive Rudinsky sign. So for Kernig's, this requires laying on the back and straightening the leg. It's very, very painful if the patient has meningitis. And positive Rudinsky's is when the neck is flexed, the hip and knees also flex too, kind of like folding a beach chair. So the memory trick is the Kernig crinkle. When the knees are straightened up, the clients crinkle up in pain. And the Rudinsky beach chair is the other memory trick. The body kind of folds up like a beach chair when the neck is flexed. Now, Kaplan had a question about this, asking a client with suspected meningitis, when the neck flexes, the hip and knees also flex. What is the priority action? So this definitely sounds like a Brudinsky beach chair to me. So the answer was to immediately report the finding to the HCP. Now, as far as imaging, we do a CT scan that is done before a lumbar puncture, since a lumbar puncture can worsen that ICP. So we do a CAT scan to kind of rule out that increased ICP by simply taking a picture of the brain. Now, as far as LP, or lumbar puncture, also known as a spinal tap, this test is done to test the CSF, that cerebral spinal fluid, for infection. So the rule of thumb is viral is very clear CSF fluid, and bacterial is very bad, cloudy fluid. Now, both will have elevated WBCs, that white blood cell count, since there is an infection inside the body. Now, as far as nursing care for an LP, before the LP, we tell clients to empty their bladder. During the LP, we have the client round their back by simply putting their knees to their chest like a cannonball position, or over a bedside table to round that back. Now, don't let the NCLEX trick you here. Clients will never be prone or basically on their stomach. They'll always have a round back. Now, after the LP, the key term to write down is we monitor insertion site dressing for clear fluid. This means that leaking CSF fluid is coming out of the patient, and we must report this to the provider immediately. That's the biggest key term there. Now, as far as nursing interventions, the first action for any client suspected with meningitis is to place the client on droplet precautions. Not to check for Koenig's or Brudinsky's sign, we always do this after the client is placed on isolation. Always remember, personal protection comes first. Now, little side note here. I know droplet and airborne precautions can get a little confusing. So use our memory tricks, PIMP for droplet precautions, and MTV for airborne precautions. So just think you're on air with MTV, like music television. And think of Pimp My Ride, like that old TV show, when you're dropping your lowrider really low. So for droplet precautions, P is for pertussis, I is for influenza, that normal flu every year, M is for meningitis, specifically bacterial, and P is for pneumonia, basically pneumonia. And for airborne precautions, M is for measles, T is for TB tuberculosis, and V is for varicella. Now, a lot of test questions come from PPE here, so write this down. For droplet precautions, number 1 is surgical mask and goggles, and number 2 is a single room. Now, ATI mentioned that we teach unlicensed personnel to wear a mask. And for airborne precautions, the number 1 thing is staff must wear N95 masks. The patient has to be in a negative pressure room, the door must be closed, and here is a tricky one, write this down. When you're transporting the patient must wear a surgical mask. Now, a few different textbooks had different things to say about this, but overall, surgical mask was the most recommended when a patient leaves the room. So guys, write that down. Not N95, but surgical mask. Now, a little side note here. Don't let the NCLEX trick you here with those fundamental questions when you're putting on and taking off PPE. So when you put on or don PPE, just think the gown goes first, the mask second, goggles, and then lastly, gloves. And it's almost the exact opposite when you're taking off or doffing. Gloves are first, then the goggles, and here's the tricky one, the gown third, and then lastly, the mask fourth. Okay, now after the PPE is in place, then we take labs, specifically taking blood cultures first. And then we give antibiotics second, within 30 minutes of admission. So the memory trick, think antibiotics we give after the blood cultures are taken, for bacterial meningitis, of course. Now the NCLEX will try and trick you because they want you to prioritize, asking for a priority action if a client slips into this septic shock from meningitis. So a common NCLEX question. Client admitted for bacterial meningitis, with a really low blood pressure. What is the priority action? So the first action that you should take is to administer the bolus of IV normal saline, that isotonic fluid. Not giving IV antibiotics first, and definitely not calling the provider. Priority here to save the patient's life is giving fluids. Now, the NCLEX and nursing exam are all about prioritization. So just think, what kills the client first? That low blood pressure will kill, and this is prioritization in terms of ABCs. Since C is circulation, that client needs a bolus of normal saline to bump up that blood pressure. This is priority. Now, lastly, let's talk about the low lows to decrease that strain on the brain. We want our client to be in a dark, quiet place. So write this down. Low noise, we need a quiet room. Low light for that photophobia. And low pressure all over to decrease that strain on the brain. So no coughing, no sneezing, and definitely no bending the extremities. We want to actually raise the head of the bed at least 30 degrees to decrease that pressure on the brain and to decrease that increased ICP. And we monitor for signs and symptoms of worsening increased ICP. Remember, the earliest signs, huge NCLEX tips here. Altered level of consciousness with restlessness, irritability, and agitation, as well as decreased mental status. You guys better write that down. We have an entire video on increased ICP, but this sign is typically the most tested since it's the earliest sign. And on the NCLEX and even in your nursing career, early detection prevents the most injury. All right, guys, that wraps it up for this segment. Don't forget to take your quiz and download the study guides. MG myasthenia gravis, think dry asthenia gravity. Patients get a dry and weak body like a heavy weight of gravity. Everything gets droopy, especially the eyes. Now for pathophysiology, MG is an autoimmune disease where the body's attacking itself, attacking the neuromuscular junction that destroys acetylcholine receptors, resulting in low acetylcholine. So just think low acetylcholine, we have low secretions, resulting in a dry body. Like the Tin Man from Wizard of Oz, who's super stiff and slow because he has no oil. He needs to be lubed up to move around, right? In that same way, dry asthenia gravis, we need more acetylcholine for more secretions in order to move around. So Hesse mentions just this. What is myasthenia gravis? And the correct answer was, it's an autoimmune disease of the neuromuscular junction and is characterized by fluctuating weakness in certain muscle groups. Now, as far as signs and symptoms here, again, think myasthenia gravity, like a big heavy weight of gravity, or like a big blanket of muscle weakness. Now, the key term to know is ptosis, those droopy eyes. This is a classic symptom on all the NCLEX questions. Some question banks use the key terms decreased eye and eyelid movements. So just think of the character Sleepy from Snow White and the Seven Dwarfs. Next, we have diplopia, that double vision, dysphagia, that difficulty swallowing, and dyspnea, that difficulty breathing. Again, just think everything is getting low and slow from all that muscle weakness. Now, Kaplan mentions tiredness with the slight exertion. All right, that wraps it up for MG. Thank you so much for watching. Don't forget to take your quiz and download the study guide, as well as share with your classmates and even MS, multiple sclerosis, is an autoimmune disease where the body attacks the myelin sheaths, those sheets of fatty tissue around the nerve cells which help the body move. So the memory trick for MS, just think MS, myelin sheath destruction, so we get MS, muscle spasms and stiffness. Now, myelin sheath I call muscle sheets, since they are the protective coverings around the nerve cells in the central nervous system, the brain and spinal cord, which helps the body move by sending electrical impulses from the brain to the rest of the body. Now, a little side note for pathoterminology. Progressive demyelination of neurons is the terminology that you should know for your patho exams, as well as loss of myelin. Remember, This affects motor, sensory, and autonomic fibers. So please be sure to write those 3 down. Now, in terms of diagnostics, we do an MRI or CT scan to see plaque on the brain and spinal cord. And so think multiple scars with plaque in multiple sclerosis. We see a lot of scars. We can also do a lumbar spinal puncture, also called a spinal tap, where we see high levels of antibodies, meaning the body's own immune system is attacking itself. Now, Hesse mentions 3 to 4 millimeters of sclerotic brain plaque on an MRI. The key term there is brain plaques, is indicative of MS diagnosis, and elevated gamma globulin in cerebral spinal fluid from that lumbar puncture. So fancy words for antibodies are present. Now, specific causes are unknown, but it's linked to genetics like females, as well as environmental factors like infection, as well as vitamin D deficiency. In terms of signs and symptoms, clients with MS can look perfectly fine on the outside, but inside they can have burning sensations, numbness, and tingling. Now, during bad flare-ups, we can see the key signs, so write this down: muscle spasticity. Remember, MS is muscle spasms. That's the #1 key sign. Now, Kaplan also states that ataxia, or uncoordination and even balance impairment, as well as urinary retention and hyperreflexia of the extremities, as well as decreased concentration, and fatigue and paralysis, and even eye and vision problems like double vision, blurry, or even dark spots. Again, try not to memorize all these symptoms, but rather just think of the patho here. So just think MS, you have myelin sheath destruction leading to MS, those muscle spasms and muscle weakness all over the body. Okay, now for patho test tips. You want to be sure to write this down. Progressive weakness and paralysis, as you know. But this includes key terms, loss of coordination, and loss of bladder and bowel function. Now, it also includes vision problems. So the key terms that you should know for exams: #1, blurred vision; #2, scotoma, which is a partial loss of vision or a blind spot; and #3 is diplopia. Fancy words for double vision. So just look at the D in diplopia as D for double vision. All right, that wraps it up for MS. Thanks so much for watching. Don't forget to take your quiz and download the study guides. And please share with your classmates and even instructors. All right, I'll see you guys in the next videos. Parkinson's disease is a movement disorder where we have progressive death of neurons in the brain, resulting in low dopamine and high acetylcholine. Now, with low dopamine, we get low movement. So think you can't jump rope if you got low dope. And the other memory trick is think of no dope in the park, like keeping drugs out of the park, since there's low to no dopamine in Parkinson's. And on the other side, for high acetylcholine, just think high secretions. We get lots of drooling. Now for a few key terms that love to show up on patho exams. Be sure to write these down. Dysfunction of extrapyramidal system. Basically, involuntary movement disorders. The classic disorders of the extrapyramidal system include a variety of involuntary movement disorders. Some of these movement disorders include dyskinesia, mainly seen as a resting tremor. The next key term is a disruption of basal nuclei, that basal ganglia. This refers to a group of subcortical nuclei responsible primarily for motor control, basically movement control. So excess stimulation affects movement and posture. Naturally, we see a disruption of normal movements for the main signs and symptoms. So the top 3 manifestations to write down and know for your pathophysiology exams is #1, a resting tremor; #2, muscle rigidity; and #3, a difficulty initiating movement, known as this shuffling gait, which we'll break down in more detail in a moment. But we also see dysarthria, that impaired speech, as well as difficulty chewing and swallowing. This dysphagia, as well as drooling. Be sure to write those two down. This is from excessive acetylcholine, which makes excessive secretions with acetylcholine. And lastly, a big one here is a mask-like facial appearance, having minimal facial expressions or less facial movement. Now, to get a little bit more detailed on the top tested manifestations, let's play that segment now. Now, for signs and symptoms, the classic signs are resting tremors and lots of slow start and stop and even freezing motion, with this increased rigidity and increased muscle tone. So just think of Parkinson's like you're parking a car for the first time. Those start and stop freezing motions. This is called bradykinesia, that delay in initiation of movement. So with bradykinesia, just think brachykinesia, like you're hitting the brakes because you're parking the car for the first time. Now, the 3 signs and symptoms to write down, because these are common on a lot of question banks, is number 1, shuffling gait with key term decreased arm swinging. Number 2 is pill rolling, which kind of looks like you're rolling something between your fingers. And number 3 is the tremors at rest, aka resting tremor. So that constant movement. But oddly enough, these tremors actually decrease when a client's attention is diverted by activity. So Kaplan had a question about a client statement that indicates an understanding of tremors with Parkinson's. And the correct answer is tremors decrease when attention is diverted by activity. Now, 2 other common signs and symptoms is dysphagia, that difficulty swallowing, and the drooling, the excessive saliva. Remember, this is from excessive acetylcholine, so we get excessive secretions with more acetylcholine. Now, Hesse had a question about this, asking about the signs of Parkinson's. Select all that apply. So, propulsive shuffling gait, drooling of saliva, and decreased arm swinging. Those are the key terms there. And a common NCLEX question asks the best response by a nurse when the client states, I notice my left hand is shaking when I try to cut vegetables. Do I have Parkinson's? So a big test tip here. We always do assessment first when given the option. Always ask more questions, assess the situation, do whatever you can to get more information. So for NCLEX and nursing exams, we have to follow this nursing process. Assessing first and intervention second. So the correct answer here is tell me more about your symptoms. When did they begin? This is technically an assessment. Now, as far as diagnostics, Hesse mentions that diagnostic tests for Parkinson's include CT of the brain that will reveal cerebral atrophy, basically wasting away or destruction of brain tissue. Secondly is decreased motility in the upper GI tract. And third, positive response to low-dose carbidopa and levodopa. These are the drugs that leave more dopamine inside the body, but we'll break that down in a moment. As far as critical complications and nursing interventions, again, think of the ABCs here. So think the client has excess secretions, lots of drooling, right? So a huge risk for aspiration, basically breathing in that drool. So airway is number 1 here, so write this down. Suction at the bedside for that excess drool. And for eating, we have to have a pureed diet or small bite-sized pieces. And tissues readily available during eating. And always add thickening agents to fluids. So dysphagia, we have to monitor its swallowing. And head of the bed, we have to keep it in a high Fowler's position or basically sitting upright. So the key words here is thickening fluids and head of the bed up or sitting up. Remember, we have a high risk for aspiration. Now, Hesse had a question about how to maintain safety and also prevent constipation and malnutrition with Parkinson's. Select all that apply. So the correct options were to cut the food into bite-sized pieces, make tissues readily available during eating, and include whole grains and fruits in the diet for that constipation. All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz and download the study guides. And also feel free to share the love, share with a classmate, and even your instructor. See you guys in the next videos. Seizures are uncontrolled electrical discharges inside the brain, kind of like a fireworks show in the brain, or like a dysrhythmia in the brain. We have neurons that are randomly discharging when they're not supposed to be. Now, a key term is epilepsy. This is a long-term chronic condition with frequent seizures. So the memory trick is epilepsy, just think a pile of seizures. We just basically get a lot of them over a lifetime. Now, the common causes of seizures are typically from anything that can cause swelling or hypoxia inside the brain. So swelling from infection like meningitis swells the brain, or even trauma from a concussion or a TBI, even mass like a brain tumor or increased ICP, and even fever in infants like a febrile seizure, and withdrawal from drugs and alcohol. Now, the types of seizures, we have both generalized, meaning all over the brain, and partial, meaning only one part of the brain. So generalized were the most tested. So write this down. Tonic seizures, we typically see a tight, intense body. So just think of the T's for tonic, for T's and tight, intense. And clonic, we usually see convulsions and contractions, even clonic clicking. So when we see a tonic-clonic seizure, this is a tight and convulsive kind of seizure, formerly known as a grand mal seizure. These are the classic ones that we see in movies and TV. So Hesse had a question about this, talking about the phases of tonic-clonic seizures. We get a partial loss of consciousness, the patient falls to the ground, the body becomes stiff, or basically tight, for about 10 to 20 seconds, and then the extremities jerk for 30 to 40 seconds, and then after, the patient feels very tired and sleepy. Now, we're going to break this down in terms of the phases of a seizure later, but those are the key terms for tonic-clonic. Now, next we have atonic. So just think A for without, and tonic, that tight and tense. So without tight or tension on the muscles, the patient suddenly deflates like a balloon and hits the ground. So big risk for trauma. Next is myoclonic seizures, where we get short muscle convulsion twitching. So just think medium convulsion with myoclonic. And then lastly, we have an absent seizure, where the clients typically space out, kind of seen as daydreaming. Now, it's commonly mistaken for not paying attention. So some parents and teachers and even healthcare workers will not recognize this as the subtle signs of an absent seizure, just thinking the child's not paying attention. So we need to educate the parents as well as the other hospital staff on the key words that absent seizures can look like, keyword, daydreaming or staring off into space. So Kaplan mentions, care for a child with a history of absent seizures, monitor for brief interruptions in consciousness. So really the key words here are brief interruptions of consciousness that kind of look like daydreaming. Now, switching gears to partial seizures. Technically not a need to know for the NCLEX, but it may show up on nursing exams. So partial or focal seizures, we have two types, simple or complex. So for simple, clients are typically fully conscious and fully aware. So the body jerks and the client knows that the seizure is happening, but they can't do anything to stop it. And on the other side, for complex seizure, we have impaired or full loss of consciousness. So usually the client is not aware. They don't remember anything after the seizure happened. And typical signs are lip smacking, biting, and even picking. But once again, these are really not need to know for the NCLEX. But this next part is, so be sure to write this down. The factors that can trigger a seizure. Just think of the 5 S's for seizures. So stress, sleep deprived, that's a huge one, also known as fatigue. Strobe lights, those flashing lights, always a big NCLEX favorite. And stimulants, and then very lastly, sugar or sodium that is low. So hypoglycemia, below 70, we say that hypogly, the brain might die because of that low sugar. And hyponatremia, below 135 sodium level. Now, as far as the stages or the phases of a seizure, first is the prodromal phase. These are the warning signs before a seizure happens that leads to the famous aura phase. So guys, write this down. The aura phase is a highly tested topic. So this is typical where we see visual cues or auditory cues that happen prior to a major seizure. most likely a big tonic-clonic seizure. Now, not all clients experience or can recognize a prodromal or aura phase before the seizure happened. So, the top missed NCLEX question is a priority patient. Who should the nurse see first? And it's typically the client with a history of epilepsy who reports an aura. Now, seizures are priority because of the airway obstruction risk. Clients can easily choke on saliva and also a big risk for injury from flopping around the ground. And on the NCLEX and nursing exams, the priority is always who dies first, or what's the worst possible outcome. And it's typically not the client in pain and not the client with the scheduled meds. You kind of get the idea. So just for priority questions, think who dies first or who gets injured first. Now for the other key terms, Kaplan mentions that an aura is an unusual sensation prior to a seizure. And then a Kaplan scenario gave a scenario about a client with a seizure disorder who tells the nurse, "I smell oranges and there aren't any on my tray." What is the best response by that nurse? And the answer was, have you experienced this sensation before? So just think auras can be auditory, sensory, or visual before that seizure. There's even a famous commercial in Canada praising a brain surgeon who helped pinpoint a client's area of seizures during surgery. And this famous commercial states, "Doctor, I can smell burnt toast." And this was her aura before the seizure. So if you know any Canadians, they probably know that saying. Now next we have the ictal phase. This is the actual seizure phase. So just think ignition or igniting phase for ictal phase, since it's the actual period during the active seizure. Then comes the post-ictal phase. So this is the hangover phase. So let the name help you. Post meaning after, ictal meaning that ignition. So after this igniting phase. Remember, what goes up must come down. We go from that high brainwave activity, those fireworks in the ictal phase, to very low brainwave activity. So we see confusion, disorientation, major headaches, and typical feelings of tiredness or sleepiness. Just think post-party phase. Since it was like a party in the brain, and now you're left hungover, confused, with a headache, and tired and sleepy. So common NCLEX question talks about confusion and headache following a 20-minute long seizure. We document this as the post-ictal phase. Okay, this next part is highly tested since it's the most deadly out of all the seizures here. So write this down. Status epilepticus is a medical emergency. Always an NCLEX favorite here. We're talking an extra large seizure. So bad that it cuts off oxygen to the brain, causing brain damage and lifelong effects. So remember these key points. Any seizure that lasts 5 minutes or longer, we're talking one seizure there, or it could be a 30-minute long seizure with repeat seizure activity. The number one priority here, write this down, is to stop the seizure. Obviously, after the airway and breathing are secure. So the number one thing in stopping the seizure is IV or rectal benzodiazepines. Always use first to rapidly control any type of seizure. And rectally is often ordered if IV starts can be problematic due to those violent convulsions. So benzos ending in PAM and LAM. Write these down. Lorazepam, brand name Ativan, and diazepam, brand name Valium. They increase GABA inside the brain to help calm and sedate the brain. So we call GABA our grandma. Just think calm and sedating brain. It's the first drug we give to stop a seizure. So when you get an exam question about a client with a history of epilepsy or a client with a VP shunt, or really anyone at high risk for seizures, watch out for the keyword status epilepticus. Just think status a pile of seizures. Big, huge medical emergency because it's very dangerous. Remember, the first intervention here is to administer diazepam rectally or IV. Now, don't let the NCLEX trick you here. Do not further assess the patient. We're not doing a CT scan. We're not even doing neurochecks. Status epilepticus will kill your patient, so you must give PAM and LAM ending drugs first. Now, as far as diagnostics, we use imaging like an MRI or CT scan to look for abnormalities like tumors or other causes in the brain, but the one to know for exams and on the NCLEX is an EEG, an electroencephalography. Whew, talk about a mouthful. So this assesses the electrical activity inside the brain by placing really sticky electrodes on the scalp. So the key points to write down is we must wash the hair before going to this type of exam, just to make sure those stickies actually stick. And no caffeine or stimulants about 12 to 24 hours before. Again, not even decaf coffee or black tea. Both of these still have trace amounts of caffeine. And no seizure meds are taken, and no sleep is actually preferred. That is a common mistake that most students make. So write this down. Sleep deprivation is best. We want that brain to be unstable to see and pinpoint triggers. And then lastly, yes, you can eat before the test. No need for NPO. So Kaplan states, a patient teaching for an EEG, this procedure is not painful, but you must remain still. And avoid black tea, that key word, before the test because of those trace amounts of caffeine. Now, don't get tricked here. An EEG sounds a lot like an ECG, that electrocardiogram, to measure heart rhythms. So the memory trick we use is an EEG, just think of an egghead, since electrical activity is measured inside your egghead. And an ECG has a C, so just think C for cardiac rhythm. Now for interventions during a seizure, write this down, the number one thing is airway. We have to turn the clients to the side and prepare for suctioning, which is typically done after a seizure, but airway is always priority here. So turning the patient to the side helps to drain saliva and prevents the tongue from occluding the airway. Now, don't let the NCLEX trick you here. We never insert anything into the patient's mouth, and we never restrain or hold down the patient's arms. So no tongue depressors or no bite guards during seizures. It's very dangerous to insert anything into the client's mouth, especially if the teeth are clenched. And never hold down the patient's arm or restrain them during a seizure. Many students get this wrong since they see it being done in the movies. Now, another key term is call for help and stay with the client. Never leave the client's bedside, since they can flop over and choke on their own drool, which is a big airway safety risk. And always call for help, guys, this is key, so that the other team members can get medications. Again, the number one goal here is to stop the seizures after the airway is secured. The number one drug we use to stop those seizures are benzos ending in PAM and LAM. Now, typically the top two tested are lorazepam, brand name Ativan, and diazepam, brand name Valium. Remember, inserting rectally or IV. Lastly, we can protect from injury like loosening restrictive clothing around the neck and the chest, offering safety with protection from clearing the area of any objects, and patting the side rails. And then after a seizure activity, we always record the time, assess the level of consciousness, do neurochecks and vitals, and very last, we prepare for suctioning. Again, we typically use suction after seizures, since we don't want to place anything into the patient's mouth during the active seizure. So HESI question had these key points. You observe and record seizure activity. You ease the patient onto the floor if they're having a standing seizure. Kaplan mentioned this too, by the way. And we protect the patient from injury. And ATI had 3 different questions. So question 1 was first priority for a client having a seizure. We turn the client to the side to protect that airway. The second question was about a tonic-clonic seizure nursing interventions. So the key term was to loosen restrictive clothing, that was mentioned twice by ATI and once by HESI, and prepare to suction the client's airway. And the third question was about a client who was at risk for seizures. The priority was to ensure a patent IV in order to give those benzos, ending in PAM and LAM, as the first drug we give if a seizure actually happens. All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz and download the Spinal cord injuries are caused by trauma to the spinal cord, like falling from a horse, a slip and fall, or even a car crash. Now, for the patho, it's very important to know the anatomy first here. The big injuries stem from the top three: the cervical, thoracic, and lumbar. But we also have sacral and coccygeal. So the phone number memory trick to use for each vertebrae is 712554. Now, a little side note for your pathophysiology exams. Cervical spinal injuries are from hyperextension or hyperflexion of the neck. And the patho is simple here. Lacerations of nerve tissue by bone fragments results in permanent loss of conduction, meaning that spinal cord is severed or cut. Kind of like cutting telephone lines. The spine can no longer transport messages to feel or even move the rest of the body. Now, a complete transection is complete laceration of the spinal cord. We have irreversible loss of sensory and motor function below the level of injury. The key term there is below the level of injury. Fancy words for loss of feeling or sensory and a loss of motor below that level of injury. Now, a partial transection is partial laceration of the spinal cord. Now, there is possible recovery of some function, as the spinal cord is only partially lacerated or partially cut. Now, for bruising, we see a bruised spinal cord, also known as contusion. This is reversible damage as the inflammation subsides, as there's no laceration or cuts in the spinal cord itself. Now, for prolonged ischemia and necrosis, ischemia is that lack of oxygen or perfusion to the tissues, resulting in tissue death, that necrosis. So remember, oxygen is the money of the body. We say no money, no honey. So no oxygen, no life. The body goes broke and dies. So naturally, with tissue death in the spinal cord, we see permanent damage as the tissues die. And also damaged tissues release epinephrine and norepinephrine, and also causing vasoconstriction, which dominoes into an interesting complication called autonomic dysreflexia, which we cover at the end of this video. Now, for the key signs and symptoms to write down. Cervical injuries are injuries in the neck region, typically resulting in paralysis below the level of injury, resulting in quadriplegia, 4 limbs that are paralyzed. So simply think quad means 4, and plegia sounds like paralysis. Now, the key sign here is breathing is impaired. This is big time life-threatening, and it happens to a lot of sports figures, which is very, very sad. Now, for thoracic injury, just think T for the trunk of the body. We have paralysis in the lower extremities, known as paraplegic. So just think paraplegic is like a pair of legs. So the legs and pelvic organs are affected. Now, lastly, lumbar injury, just think the double L's. Legs and leaky bladder are key signs and symptoms, because below the level of injury gets affected. So once again, to recap, the memory trick here is C for cervical injury. You just C, can't move anything. And then T for thoracic injury, just think T for 2 legs and trunk is affected, including the pelvic organs. And then lastly, the L for lumbar, just think the 2 L's. Legs and leaky bladder are key manifestations. Now, diagnostics are very simple here. We just simply take a picture of the body. So X-rays are done after trauma, as well as a CT scan and MRI. But really, the critical complications are priority for the NCLEX. And ATI had a question about neurogenic shock. Basically, anytime you hear the word shock, just think severe hypotension with shock. Blood pressure is so low that it will kill your patient. So watch out for the 3 Ds of neurogenic shock. D for decreased blood pressure, dependent edema, as well as dysregulation of temperature. This was only mentioned by ATI primarily. Another critical manifestation was autonomic dysreflexia, which can kill your patient. But we'll cover that in a separate video right after this. As far as pharmacology, for the neurogenic shock, we give IV fluids and vasopressors to increase that blood pressure. So just think vasopressors press up the blood pressure. And we also give steroids ending in zone to decrease the swelling. So dexamethasone and prednisone. Again, just think zones decrease the swelling in the body. And we can also give muscle relaxants over the long term to decrease those muscle spasms. Now, lastly, for surgery, we use cervical spine bracing. also known as a halo traction device, and also called a crown or a vest. Now, this wasn't mentioned by any other question banks, but it may show up on your nursing exam. So the key priority is infection risk. So you must educate the patients to have no showers, only a sponge bath. And we assess the pin sites inside the head for infection. So remember, red, warm, or smelly drainage typically indicates an infection. Autonomic dysreflexia is a must-know for the NCLEX and nursing exams because it's very deadly. Now, the key point to write down is that it occurs in high spinal cord injuries above that T6 area. So write that down. Any injury above that T6. So it could be cervical and anything higher in that thoracic area. Now, this condition is very deadly because it results in extremely high blood pressure, like up to 300 systolic, which is really deadly because of the risk for a stroke from that high blood pressure that pounds against those tiny blood vessels in the brain. Now, exams love to ask about the causes, so write this down. It can come from a tight bladder, bowel, or even close. So for the bladder, the key words they use is full or distended. That's a huge NCLEX tip right there. And for the bowels, they use constipation and even tight clothing from like gowns or even skin breakdown. Now, why is the blood pressure so high? Well, the patho is pretty simple here. So a spinal cord injury above that T6 area, we have blocked communication in the spinal cord itself, resulting in miscommunication of the SNS and the PNS in the autonomic nervous system. Hence the name autonomic dysreflexia, kind of like dysfunctioning. So think the SNS speeds up the vital signs via vasoconstriction, so we have high blood pressure. And the PNS puts the brakes on the vital signs via vasodilation with low blood pressure. Normally, these two balance each other out, but this autonomic system is dysfunctioning in autonomic dysreflexia. So we end up with vasodilation above the injury site and vasoconstriction below the injury site, resulting in sort of a teeter-totter of mixed signals from high blood pressure to low heart rate, sort of like a tug-of-war, as the SNS and PNS are miscommunicating here. So the key signs and symptoms to write down, we have severe hypertension, which typically kills our patient from a stroke. So remember, up to 300 systolic from that high SNS, that sympathetic nervous system, as well as a throbbing headache, obviously from all that blood pressure pounding against the brain. And we also get bradycardia, that low heart rate below 60 from the PNS. And then also facial flushing and nasal congestion. Now, Kaplan and ATI had questions about this, and the correct options were bradycardia, below 60 beats per minute, piloerection, fancy words for goosebumps, and diaphoresis above the injury site. So basically that's sweating above the T6 area. Now, the top missed NCLEX questions were in terms of priority patients. So a patient with diaphoresis, hypertension, and bradycardia with a history of a T4, that's the key term there, spinal injury. So remember, the key term in any question, always pick out what kills the patient first. So this question says spinal injury above that T6 area and high blood pressure. So anytime you see the word spinal injury in a question, always think what's the worst case scenario, or basically what kills your patient first. In any spinal cord injury and high blood pressure, you have to think dysreflexia, autonomic dysreflexia. So for interventions, the emergency treatment includes correcting the cause. So first, we notify the HCP provider. Second, we correct the cause. So we have to assess what's causing the problem. So for bladder assessment, the key terms that were used were palpate the bladder, use a bladder scanner, and check the Foley for kinks. Just think anything that causes the bladder to be distended can cause autonomic dysreflexia with our spinal cord injury patients. So even sediment inside the Foley drainage device itself can clog the Foley with chunky urine and basically back up that bladder, causing distension. Next is bowel assessment. We always look, listen, and feel to the abdomen and check for the last bowel movement. And then remove constrictive clothing, huge NCLEX tip right there again. Restrictive clothing and skin breakdown, also a cause. And then lastly, we put measuring blood pressure because that's not necessarily correcting the cause. It's just taking an assessment here. And then number 3, blood pressure meds are done after the assessment because the number one thing we're doing here is correcting the cause. Antihypertensive drugs always come after assessments, and correcting the causes here. I'm going to drill that into your brain. So again, big NCLEX tip. We always assess first and try to correct causes before throwing medication at it, since uncontrolled sympathetic activity will resolve when the underlying causes are corrected here. Now, a common NCLEX question was the initial action for a cervical spine injury with a throbbing headache, nausea, and, second key term, elevated blood pressure. The answer was to palpate the bladder. So always look for the key terms here. Cervical spine injury, so that's above our T6 area, and elevated blood pressure. We always have to assess the problem. So assessing the bladder. Now don't let the NCLEX trick you here. The initial action is assessment and not administering any antihypertensive drugs initially. Remember, on the NCLEX and nursing exams, we always assess first and then do interventions second. Now, a Kaplan question mentions a client with a spinal cord injury above that T3 is reporting a headache and nasal congestion with profuse sweating and piloerection. What is the first action? Again, look for the key terms here. Spinal injury above that T6 area. We must correct the causes here. So the correct answer was to check the urinary catheter for kinks. And another NCLEX question said priority interventions for a T1 spinal cord injury with flushing diaphoresis and a pulse of 58. Select all that apply. So remember, the key term here is the spinal cord injury above that T6. So the correct options were assessing for bladder distension, removing tight clothing, measuring the blood pressure, and a high Fowler's position. So raising that head of the bed. Remember, do not lower the head of the bed. And not on left lateral position, and definitely not Trendelenburg position here. That would put way too much blood flow to the brain with a already high blood pressure. Now, a trick question here. Do we give analgesic pain meds or NSAIDs for the headache? Very interesting. Well, no. The first thing we do is correct the causes. Now, don't let the NCLEX trick you here. The headache is caused by that high blood pressure pounding against the brain. So the priority actions are always to correct that bladder distension, bowel assessment, and even remove constrictive clothing. So then the high blood pressure will be fixed on its own and the headache will naturally resolve. All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz and download the study guides. And also feel free to share the love. Strokes, also called a CVA, is what happens when the brain lacks oxygen, typically due to a clot in a blood vessel, which cuts off oxygen supply to the brain. So, just like any organ without oxygen, the brain begins to die. But strokes can also be caused by narrowed blood vessel, which decreases oxygen delivery to the brain, like in atherosclerosis, or even sudden rupture of a vessel in the brain, known as an aneurysm. Either way, the brain lacks oxygen and tissues die. Now for the type of strokes, we have TIA, known as a transient ischemic attack, which I remember TIA as a tiny stroke, since we have a tiny lack of oxygen. Now, breaking down the medical terminology, transient means lasting only a short time, ischemic means a lack of oxygen, and attack means it happens suddenly. But TIAs come and go and often resolve by themselves. Now, the other types of strokes are more permanent. So a CVA, a cerebral vascular accident, just think CVAs are more serious. We have no oxygen, which means long-term permanent damage. Now there are two types of CVAs. Ischemic, meaning that low oxygen, typically from a blood clot that cuts off oxygen supply, also called embolic or thrombotic stroke. And a hemorrhagic stroke, like an aneurysm. So bleeding from a ruptured blood vessel, resulting in high risk for increased ICP. Now, the number one risk factor and cause to know for the NCLEX and nursing exams, write this down, is hypertension over 140 systolic. This one was stressed as the single most important risk factor to prevent a stroke. So the key term for prevention was to instruct the patient to take their antihypertensive medications regularly, since the stroke risk can be decreased by up to 50% when hypertension is controlled. So Hesse mentions the highest risk for a stroke was that hypertension over 140 systolic. And Kaplan says that hypertension was the highest risk factor for a CVA. Well, why though? Well, think of the patho here. Uncontrolled hypertension pounds those little blood vessels inside the brain, stretching them out and making them very fragile. Now, a tricky NCLEX question for a client recovering from a stroke with hypertension over 200 systolic, the intervention was to keep the systolic blood pressure over 170 for the first 24 to 48 hours. This makes sure we lower the pressure slowly, sort of like landing a plane. We land it slow and smooth, no big drops. This prevents us from crashing into hypotension. So remember, we need to land that plane slow and steady. Now, for the other causes that weren't really tested, smoking scars the blood vessels, making them weak. Hyperlipidemia, that high cholesterol, adds fatty buildup underneath those scarred vessels to form plaque. And uncontrolled diabetes, we get very thick, syrupy blood, which puts loads of pressure on the blood vessels and over time destroys the whole body. And even increased risk for clots, like in clients with atrial fibrillation and even heart valve malfunctions, where blood can sort of swirl around the heart, resulting in clots that can eventually travel to the brain. Now, for the key signs and symptoms, the most tested key term on 5 different question banks was, write this down, hemiparesis, or unilateral weakness. That one-sided weakness that was new or sudden, with key term arm drift. Guys, write that down. These key terms came up 90% of the time. So if you see these terms, new or sudden, or even one-sided weakness, or even arm drift, you have to assume that it's a stroke, and we have to notify the provider immediately. So for quick assessment, we use the popular acronym FAST, since acting fast saves lives. So F for facial and smile drooping, A for arm drift, that one-sided weakness, S for speech impairment from the mouth and tongue, and then T for time. We have to call 911 and get a CT scan immediately for any of these signs and symptoms. Since this is known as the golden hour, we only have 1 hour to seek medical attention due to the lack of oxygen supply to the brain. Remember, time is brain. Now, for hemorrhagic strokes, that ruptured cerebral aneurysm, we get a key sign for severe headache. Now, this is very different than any other type of headache. It's way worse than migraines. Some clients even say that it's the worst headache of their life, often called the silent killers, because a small bleed can go undetected for years before a major rupture without warning. So a common NCLEX question is, the most concerning patient statement with diplopia and new weakness and onset of vomiting without nausea. I have the worst headache of my life. The key term there is worst headache, since blood is filling up that brain, causing massive increased ICP. Now, since strokes affect one side of the body, a left brain stroke will affect the right side of the body, and vice versa. A right-sided stroke will affect the left side of the body. So to help you remember this, just think of an X coming out of the brain and pointing down to the opposite sides of the body. So write this down. Left brain controls the L's, language and logic. So we see dysphagia, difficulty speaking. So just think the S in dysphagia, S for speech. And we get reading and writing problems. And we get right-sided hemiparesis, that one-sided weakness, resulting in right-sided neglect, basically ignoring that side of the body due to the half vision from visual deficits. And on the other side, the right brain, think of the R's, reckless and really creative. So we get lack of impulse control and behavioral changes, as well as left hemiparesis, that one-sided weakness on the left side, leading to left-sided neglect from ignoring that body due to the half vision. Now, a common NCLEX question is teaching for families of patients with right-sided brain injury. So remember, R for right side, R for reckless. So the correct answer is always lack of impulse control and behavioral changes. Now, the ATI mentions manifestations of right-sided hemispheric stroke. So expected findings is visual and spatial deficits, left homonymous hemianopsia, basically that one-sided vision, as well as one-sided neglect. These are typical for almost every stroke patient. Now for diagnostics, the number one goal here, as mentioned before, is a CT scan immediately. We need to take a picture of the brain and pinpoint the exact cause. We need to know this first before we start treatment, since treatment will be very different depending on the type of strokes. Okay, now another diagnostic exam that you should be familiar with for your pathophysiology exams. The NIH Stroke Scale. Now this is a 15-item scale that measures 11 stroke-related deficits. So this tool is used by healthcare providers to objectively measure the pathophysiological impact caused by a stroke. Now as you can see, it's a big old list with line items that correlate to a score, rating the client's ability to complete a task. Now this is very basic in terms of a scorecard. So let me show you what exactly it looks like in the hospital setting. As you can see, there's a lot of boxes here and it's very detailed on the chart. Now here's the key point. When implemented early and measured at the 24-hour mark of when the stroke occurred, it is highly predictive of the long-term outcome, basically the prognosis. So it's a common diagnostic method for quickly assessing both the severity of a stroke and the long-term outcomes, or the prognosis. Now you're probably asking yourself, what's a good score versus a bad score? Well, it's funny you ask, because 0, we have no stroke symptoms, 1 to 4 is minor stroke symptoms. Now 5 to 15 is moderate, 16 to 20 is moderate to severe, and anywhere between 21 and 42, which is the max score, is a severe stroke. For example, on the right side, this client is experiencing a moderate stroke. Now, you typically don't need to memorize all the numbers on this chart here, but just in case you do, now you know it. So in terms of treatment for pharmacology, strokes with clots, we give a clot buster. So write this down. Thrombolytics are given within 4.5 hours of the onset of the symptoms. So TPA and those ending in ACE, like alteplase and streptokinase. Common exam questions, especially select all that apply, come from this section. So the key terms are give thrombolytics in 4.5 hours of the onset of the symptoms. So if a stroke happens 2 hours prior to the hospital, you know you have about 2.5 hours to give the clot buster. Now on the other side, if stroke is hemorrhagic, we can't give a clot buster since there's no clot. So number one thing we do is we implement seizure precautions and strict bed rest, since increased ICP is a big risk here from that brain filling up with blood. Now the next thing is no blood thinners, since it will make the bleeding worse. So no aspirin and no clopidogrel, or antiplatelets, and no heparin or enoxaparin, no warfarin, and definitely no thrombolytics. And then very lastly, limit any activity that may increase ICP. A big one on most question banks was key term, administer PRN stool softeners daily to prevent straining and bearing down during those bowel movements. Now, 2 tricky NCLEX questions. So the first one was interventions for the initial plan of care for a patient with suspected embolic stroke. Select all that apply. So the key term here is embolic, or basically that emboli, meaning a blood clot. So number 1, we obtain a stat CT of the head to determine the type of stroke. Number 2, perform neuroassessment. And then number 3, prepare to initiate alteplase within 4.5 hours of the onset of the symptoms. Now the second common question was a priority nursing action for a patient with left-sided weakness, the lack of verbal response, and a drooping face. The priority here was to maintain a patent airway. So when given the option, always maintain the airway first. Yes, these are symptoms of a stroke, and yes, it's important to fully assess as well as get to a CT scan, but priority here is always to remain and maintain the ABCs. Remember, airway is always first. All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz and download the study guides. And also feel free to share the love, share with a classmate, and even your instructor. See you guys in the next videos. Now for the case study on strokes. A 75-year-old African American man presents to the emergency department with right upper and lower extremity weakness, left-sided facial droop, and slurred speech, starting 2 hours before arrival to the ER. The client reports a history of hypertension and elevated cholesterol. So question number 1. What are this client's modifiable and non-modifiable risk factors for thrombotic CVA? So pause the screen and try your best to answer this question. Okay, let's break it down. Remember, modifiable means things that the client can change, or basically modify. And risk factors are those things that put the client at the highest risk for a stroke. So for modifiable, hypertension and elevated cholesterol. Yes, the client can lower their blood pressure and cholesterol with diet, exercise, and medication. Now, in terms of non-modifiable, age and race are non-changeable. Well, at least not with the technology we have today. Now, question 2. What is the underlying pathophysiology of a thrombotic CVA? So pause the screen and try your best to answer this question. Okay, let's break it down. Remember, the key terms are thrombotic CVA. This means a stroke caused by a thrombus, or basically a blood clot in the brain. So risk factors such as atherosclerosis, hypertension, obesity, diabetes, and others lead to key terms here: plaque formation within the endothelial tissue of the major cerebral artery. Now, plaque formation leads to a damaging inflammatory response within the endothelial lining, causing plaque weakening and rupture. So plaque rupture causes occlusion of the cerebral artery, and if occlusion is complete, well then cerebral ischemia, basically that low oxygen, results and leads to death of neurons. Basically brain tissue death from the lack of oxygen. Now, question number 3. Which additional priority assessments should the nurse perform at this time? So pause the screen, try your best to answer this question. Okay, this question is a priority-based question. So think, what is the most important assessment to conduct right now? So think of the memory trick FAST for stroke assessment. F for facial drooping, A is for arm drift, S is for speech, and T is for time. So what's the significance of the FAST assessment, and why is it such a big deal? Well, these are priority assessments that should be rapidly performed on any suspected CVA client. So remember, the quicker the stroke symptoms or manifestations are recognized and treated, the more likely the client will receive brain-saving interventions, such as thrombolytics. Now, the next thing we do is vital signs, as this should always be done as baseline, specifically blood pressure, and also blood glucose, just to see if the client is having low glucose, basically that low sugar. These signs can be very similar to stroke manifestations. Now, moving on to question number 4. What is the significance of the NIH stroke scale? Pause the screen and try your best to answer this question. So remember, this is a huge list from the full video. Okay, now for the answer. The NIH stroke scale is a 15-item list to measure stroke-related deficits that, when measured at the 24-hour mark, is highly predictive of long-term outcomes. Please be sure to write down these key terms here that are highlighted and bolded. Now, it is a common diagnostic method for quickly assessing the severity of a stroke experienced by a client. So please be sure to pause the screen and write down the highlighted and bolded words here, as these are the most tested. Now for the practice questions on CVA stroke. Question 1. The wife of a client who's had a stroke reports that her husband woke up with slurred speech and was unable to get out of bed without assistance. 2 days later, the client is still experiencing neurological deficits. The client likely experienced a pause the screen and try your best to answer this question in 60 seconds or less. Okay, following our question breakdown strategy. First, always look at the key terms in the question. So the client had a stroke in the past. They have slurred speech and they're unable to get out of bed. And 2 days later, still experiencing neurodeficits. Now, the second thing, think of a few things you know about those key terms. Now, this sounds a lot like a new stroke, but not a hemorrhagic stroke, that brain bleed, as this type of stroke typically presents with a severe headache as the brain swells with blood. And this question did not state a headache. So looking at the options here. Option A, hemorrhagic stroke, is incorrect. There's no mention of that severe headache. Now option B, thrombolytic ischemic stroke. So yes, this is the most correct, as all the signs and symptoms are classic manifestations of a CVA stroke. Now options C and D are incorrect because a syncopal event is fainting. So the client is weak but not dizzy or faint. And D, the TIA, the transient ischemic attack. Now this one is very close, but it's wrong. So remember, TIAs is that tiny lack of oxygen that comes and goes with minor signs and symptoms. And this question states that the signs and symptoms are progressively getting worse over 2 days. So this makes option B the most correct. Now moving on to question 2. The nurse is caring for a client who has suffered a transient ischemic attack, that TIA. When asked by the client's spouse what to expect regarding recovery, how does the nurse respond? So pause your screen and try your best to answer this question in about 60 seconds or less. Okay, so let's break this question down. The first thing we do is look at the key terms in the question. So TIA, we have to think tiny lack of oxygen with manifestations that come and go, and what to expect regarding recovery. So number 2, think of a few things you know about those key terms. So remember, TIAs typically resolve by itself within a few days. Now looking at the options. Option A, your spouse should recover fully within 6 months or 1 year. No, recovery lasts only 1 to 3 days. So option B, signs and symptoms of TIAs typically do not resolve without surgical intervention. No, this is completely incorrect. Remember, TIAs resolve on their own without surgery. Now, option C, your spouse should recover at least 50% of lost function within 2 weeks. No, another incorrect option. Remember, TIAs are that lack of oxygen with signs and symptoms that typically resolve within a few days. So option D is the most correct. Symptoms of a TIA typically resolve on their own within 24 to 72 hours. Yes, fully resolving within 1 to 3 days. Now moving on to question 3. A client who suffered a stroke 1 week ago is demonstrating trouble with maintaining balance. Which area of the brain does the nurse suspect is affected based upon this finding? So pause the screen and try your best to answer this question. Okay, so let's break it down using our 2-step strategy. So number 1, look at the key terms in the question. We have stroke, that was 1 week ago. Trouble maintaining balance, the big key term there is balance. And which area of the brain is affected? So number 2, think of a few things you know about those key terms. So the key term here is balance. Remember, balance is controlled by the cerebellum. So use the memory trick, cerebalance for cerebellum. So option B would be the most correct choice, as it's cerebellum. Now moving on to question 4. The nurse is assessing a client who is displaying signs and symptoms of a stroke. Which question will best help to differentiate between a thrombotic stroke and a hemorrhagic stroke? So pause the screen and try your best to answer this question. All right, let's break it down using our 2-step strategy. So first, look at the key terms in the question. We have signs and symptoms of a stroke. And the question's asking which question will best help to differentiate between a thrombotic versus a hemorrhagic stroke. Now, number two, think of a few things you know about those key terms. So, manifestations of a thrombotic stroke, just remember, thrombotic is a thrombus, or basically a blood clot, that cuts off all oxygen supply to the brain, resulting in major signs and symptoms like facial droop and one-sided weakness. And a hemorrhagic stroke is hemorrhage, or basically a burst blood vessel within the brain, typically caused by uncontrolled high blood pressure, that hypertension, that pops a little tiny blood vessel in the brain, resulting in a brain bleed. And the main sign and symptom here is a headache as the brain fills with blood. So option A, do you have a history of poorly controlled hypertension? Yes, this is the most correct, as hypertension is the number one cause of a hemorrhagic stroke. Now, option B, C, and D are all incorrect, as they are not specific enough to pinpoint the root cause of the hemorrhagic stroke. And lastly, question number 5. The nurse is conducting discharge teaching with a client who suffered a stroke. Which modifiable risk factors should the nurse teach the client to eliminate? Select all that apply. So pause the screen and try your best to answer this question in about 60 seconds or less. Okay, let's break it down following the question breakdown strategy. So first, look at the key terms in the question here. The question states discharge teaching after a stroke, specifically looking for modifiable risk factors to eliminate. Now, number 2, think of a few things you know about those key terms. So remember, modifiable risk factors are things the client can change. Now, let's look at the options. So option A, smoking. Yes, smoking scars the blood vessels, leading to atherosclerosis, which we call atherosclerosis, those hard, narrow blood vessels. Now, option B and C are incorrect. Family history you can't change, and advanced age. Not even with all the plastic surgery in the world can we change your age. Now, option D and E are correct. A sedentary lifestyle. Remember, sedentary is that sitting lifestyle, basically that lazy lifestyle. Clients can get up and walk around and move the blood around the body, increasing that circulation. And option E is also correct, that obesity. Clients can always lose weight and feel great. So option A, D, and E are correct here. All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz and download